nobody chose. And it had happened even last year. They said, no, they're going to show, studies are going to come. I spent 2 hours there, nobody showed. So do you prefer Sakai? You prefer to come in for physical office hours? Sakai? Okay, perfect. All right, so we'll figure that out and we'll send that to you. Okay, so we were talking about, I don't know if you remember, but we were talking about combination oral contraceptive. And we spent a lot of time in the oral pills. We were talking about the complications associated with combination of contraceptive. We finished up with breast cancer risk, and now we're going to talk about other cancer risks, which actually are quite beneficial. So we finished that, then we talk about, besides oral combination oral contraceptive, we will talk about other dosage forms for combination hormones, and then we'll talk about progestin only and long-acting reversible contraception. So just to give you an overview of what we're doing today while we get started. Okay, so when we talk about cancer risk, we actually talked a little bit about the possibility of an increased risk of breast cancer, particularly when we look at large studies that also including those formulations that I told you had estrogen levels of 50 or above. When we look at the data of the studies for the American formulation, the formulations available in the market, it doesn't seem that we see that increased risk, so that's good news. When we talk about ovarian cancer and endometrial cancer, we actually see very significant beneficial effects in reducing the risk of this cancer. And you can see from the slide that this beneficial effect, even with short duration of action, but it's actually related up to 60%, for example, when we look at ovarian cancer and 12 years of use, that effect relates to duration of therapy. But even after this continuation of therapy, we see a beneficial effect in decreasing the risk of ovarian cancer and endometrial cancer. Now keep this in mind, because when we talk about hormonal replacement therapy in menopause, okay, the effects are going to be different. So I don't want you to confuse this too, okay? In terms of cervical cancer, it seems that there's an increased risk, particularly if the woman has HPV and is using oral contraceptive. Keep in mind again that HPV is a risk factor for cervical cancer. In terms of drug interaction, a couple of things very important for doctors or pharmacists to know, right? This is a very common medication that you're going to get, and theoretically, there's a lot of interactions. Obviously, you need to get updated into this, so I'll tell you what the eligibility criteria tell us right now. These guidelines are current and are of 2016. I'll tell you about the potential and then the official interaction. So keep in mind, very important, that with this lower dose formulation, like 10 micrograms of estrogen, right, 20 micrograms of estrogen, there's an increased risk of decreasing level and decreased efficacy with these interactions, okay? So when we look at proven or potential risks, we're talking about pretty much 3 types of drug. Rifampin and rifabutin, anticonvulsants, and you have the list in there, and then ritonavir. Those drugs actually do decrease the levels, and it will decrease the efficacy of contraception. Now, if you look at the bottom of the slide, I have here that the eligibility criteria tell us that we do not see decreased levels of hormone. We're talking about estrogen and progesterone when we give patients, and you have a very long list here of antibiotics. But there is a potential, right, particularly in low dose products, that, remember that, what is the pharmacokinetic interaction that we talked about, that it can decrease? Actually, what level could decrease estrogen or progesterone? Who remembers? Estrogen, right? And how does it do it? Enterohepatic recirculation. So potentially, right, if we give antibiotic and we kill the bacteria that we need for that enterohepatic recirculation, right, theoretically your levels of estrogen will be lower. And the possibility of that is higher in lower formulations that are newer, that are not studied as that well. So guess what? Look at the recommendation. Advise the small risk of interaction, and if desired, use additional form of contraception. I kind of disagree with that. What do you think I say? Use it, okay? You don't want to have a baby and you're in a low formulation, right? You should use condoms. If you, particularly in patients with 20 and 10, that's what I'm telling you, just advise that, okay? Even though it's a small risk, well, there is a risk. And again, it's more so if the patient had breakthrough bleeding. So if you have a patient with 10, especially 10 milligrams of estrogen, on antibiotics, okay, particularly a younger patient that does not have decreased fertility, just advise them, okay? Because then we're talking about the consequences of that. Now, so we talked about all sort of formulation, we talked about all sort of doses, so I'm gonna briefly give you a general overview of then how do we go about selecting these products. Those of you that work in pharmacy have seen how many different type of formulation are there. How do we go about it? Well, the most important thing is that all products, guess what, are safe and effective, right? Otherwise they wouldn't have been approved. So any product, and all the products in general have similar efficacy. So technically, any product is a good choice. Normally we'll choose products of about 30 to 35 micrograms. As you can see, we can consider lower doses for specific populations. For example, patients that are older, that might have high blood pressure, hopefully control, otherwise we'll run into a problem. Or patients that are smokers and so forth, we can consider lower dose preparations. But pretty much all the preparations are safe and effective, and depending on any specific medical condition, certainly we can select more appropriate agents, and we'll talk about that shortly when we go over an overview. Pretty much when we start oral contraceptives, you need to get a good history to make sure you don't have any contraindications. You measure blood pressure, and pretty much you don't need to see the patient until a year, for follow-up for a year, unless again the patient has high blood pressure, and you encourage the patient to get the blood pressure checked periodically. So overall, any product is that is available is a possibility, but certainly there's certain products that will benefit patients more than others. In terms of initiating therapy, as I said, we kind of prefer to start the first Sunday, right after the first day of the menstrual period, because we talked about not having periods on weekend. But another important way to start it is do a pregnancy test at the clinic and then start the contraception right there. So with that, and again, we'll talk a little more about specific populations in general when I finish all the contraception, and I have some lists in that slide, but we'll come back to those in general. So with that, we finish the oral combination contraceptive. Two other dosage form, one the patch, right, and we'll start with that, and then the ring. So we can do combination estrogen and progesterone in a patch, same concept, okay? So the patient will have to put a new patch, right, every week for 3 weeks, and then a week off of the patch. Things that we need to know in terms of being pharmacists, that obviously you use a patch, remember that first pass metabolism doesn't happen. And a concern with that is actually that these patients, if you see the bottom of the slide, they have higher exposure to estrogen. You can see here that the IUC and the Cmax is about 30% higher than a patient in a 35 microgram pill, okay? Why is that significant? The reason why it's that significant is because actually, and this is a black box warning in the patch, it has a higher risk of VTE compared to a 35 microgram pill, okay? Obviously, we're talking about not randomized controlled trials, we're talking about epidemiologic studies. That means that this is not proven, but there is an association with higher risk of DVT for the patch, and it's important that you keep that in mind. And then there's things like, for example, sauna and all of that, and exercise, that may increase the absorption of that estrogen, which potentially can make it higher. So in those patients, you may have concern using the patch, okay? The next product is a combination product, and it's a ring, it's a vaginal ring. Again, estrogen and progesterone. Quite interesting, the ring needs to be left in the vagina for 3 weeks and then taken out for a week again for having a period. You don't need to change it every week like we do with the patch. What is interesting is that if it's expelled from the body, then, and it's out of the body for more than 3 hours, then you do need to use another form of contraception. So 3 hours is not a prolonged time, so it's important that you advise patient accordingly. So everything that we talked about, combination oral contraceptives apply to these products, right? They are estrogen and progesterone. But again, these products seem to have a slightly higher risk of DVT than oral preparation. So it's important, again, to keep that in mind. That would be a concern. This slide is just, it's in your textbook. I kind of find that interesting because it's a way of remembering what to advise patient, not necessarily that I'm going to ask you anything about this, but in terms of counseling, give you a little idea of what not to forget when you're counseling patients that are getting contraception. So now we're going to talk about progestin-only contraceptives, and hold on, oops. And we start with the mini pill. So the mini pill is just that, a progestin-only pill. Couple of things different with the progestin-only pill, that combinational contraceptive. The mechanism of action, if you look here, it thickens the cervical mucus, and remember that Ehlers surge that I wanted to show you last class? It prevents that Ehlers surge. However, about 60% of the patients still have ovulation. So what does that tell you about how effective it is? It's not very effective. So very important if the patient, well, first of all, most women would have combination of contraceptive. Obviously, there's special population, like for example, if the woman have a contraindication to estrogen, and we went over some of those in the past. They use it again in patients that are lactating or postpartum after 3 weeks. We'll talk a little more about that. And maybe in older women with decreased efficacy, but certainly young women assuming that 6 out of 10 would have ovulation, this is not a very effective contraception to use. The other thing is important is, again, as we talked about earlier, is that every 24-hour pill. But even if you take it 3 hours later, okay, they recommend that a second form of contraception be used for 2 days. So it's important to keep that in mind. And another thing that is important is that, or different, is that they recommend a non-hormonal contraception mid-cycle. What happened mid-cycle? About day 14? Why is that? Oh, you're sleeping. Ovulation, right? So about day 14, wait, are you guys really bored?
I'm just tired.
Okay, day 14 of the cycle, what happens? Ovulation. That's the worst time to miss the pill, okay? So keep, at least remember that. So keep that in mind. So even if you're not missing a pill for this particular product, they recommend that. Now, on the other hand, the next progestin-only contraceptive is very, very effective, and that's depot-medroxyprogesterone acetate, okay? I'm gonna call it Depo-Provera because it's easier. Very, very effective if used appropriately and on time. It's an injectable either intramuscularly or subcutaneously. We have 2 different products. You can see that they have 2 different doses, 150 for intramuscular, 104 for subcutaneous. That is injected every 3 months. However, even the subcutaneous, need to be given at the physician office, okay? There are some advantages of progestin only. For example, patients that may have hypertension, that might be an alternative. We'll talk a little bit about eligibility and when we go over the tables at the end. So it has some advantage, some specific advantage for certain populations that we'll review in more detail. The other thing that is interesting is that it causes less ectopic pregnancy, and even though it has a contraindication in the package insert for VTE, in patients with VTE, it's certainly a better alternative, and is suggested as an alternative than combination oral contraceptives that are contraindicated if your patient has history or family history of VTE. So we'll talk about those in more detail when we do an overall of all the products. In terms of ADRs, it does cause menstrual irregularity, the most common one, amenorrhea, but it also can lead to irregular bleeding patterns. Sometimes if you give a short course, 7 to 10 days, low dose of estrogen, that improves. But again, that's a concern, particularly when the majority of the women become amenorrheic and they're not sure if they're pregnant or not. It also increases weight gain. It may increase glucose intolerance or decrease glucose tolerance, I guess. Another thing that is very interesting, there's a delayed fertility that we don't see with other products that we're going to discuss next, up to 10 months, okay? Some patients, that's the average. Sometimes it could be a year. So it's something that need to take into consideration when the patient desires a family, that delayed fertility needs to be taken into consideration. The other important consideration with Depo-Provera, very important, because we're going to talk about osteoporosis later, is that it causes osteoporosis. If you look if it's used for a long time, if you look here, there is a black box warning that it cannot be used for more than 2 years because of the increased risk of osteoporosis. If you look at the data, the bone mineral density decreases up to 6%, which is significant. If we use it in younger patients, like adolescents, they may not achieve peak bone mineral density, and you will learn later that that's a big problem, because then they'll have less bone mineral density, increased risk of osteoporosis. And then when we look at this data over time, these patients, even when we look about 6 years later, 5 years later, they have not recovered completely that bone mineral density with discontinuation. So certainly we don't want this product to be used over 2 years because of that concern. We don't know if that translates into fracture rates, but if I'm the patient, I don't want to find out if it does, right? So certainly it will be a product that we'll use for no longer than 2 years because of those concerns. At least is the way that the FDA recommend. So now we're going to talk about long-acting reversible contraception, very effective, as we will see shortly. And also, because it says here reversible contraception, pretty much the return to fertility happens right away, which again is important when planning a family. The first product that we're going to talk about are intrauterine devices. It's quite interesting to me because we used to have 2 products that nobody used because in the past they were associated with significant morbidity and even mortality. But the products that we have in the market are very, very effective, as I said, and very safe. So pretty much the way these devices work, they're implanted in the uterus wall. Obviously need to be done by a well-trained physician. And there are a couple of mechanisms of action. The one that have progestin, obviously, as we talked earlier, and thicken the cervical mucus and may prevent, act as a barrier, prevent fertilization. And then it may prevent implantation of the fertilized egg if that were to happen. There are 2 types, progestin, and there is copper IUD. There are like 4 different types of progestin IUDs, if you can see here, depending on the brand. They will last up to 3 to 5 years, okay? So they don't need to be removed up to 3 to 5 years. And then the copper IUD, which is associated with more bleeding, on irregular bleeding patterns, can be left in place up to 10 years. In terms of contraindication, normally if you know that the patient has an STD or pelvic inflammatory disease, then certainly should not be inserted on that day. It's actually quite interesting. I just went to a conference where pretty much you can do the test for PID, and if you find out that the patient had PID after you inserted that IUD, you just treat the PID. They recommend that the IUD does not be taken out. But certainly patients that have any abdominal bleeding concern, intravaginal bleeding concern with endometrial or cervical cancer, or may have a abnormality in the uterine wall, certainly those patients are contraindicated for IUDs. Patients that have breast cancer, copper IUD is fine, progestin IUD are contraindicated. Very interesting, because in the past, with concern of uterine rupture with devices, which is not something we're concerned anymore, those products were not recommended for patients that never had kids. So really, that was not something that we're using teenagers or adolescents. However, right now, they're really not good data to use in adolescents, but there's evidence that they're safe and effective in adolescents. And I was surprised to hear in that lecture that I recently went that this doctor actually was saying that he put an IUD in a 12-year-old. I don't know, but I guess it can be done. However, so it's a good option, very effective, and it's suggested that it be considered early or as early as adolescents right now. In terms of ADRs, yes, there's a slight increased risk of ectopic pregnancy. There might be concern with septic abortion. There's a slight increased risk in PID, particularly with insertion. And the risk, obviously, is higher in patients that have higher risk for PID. So not only the patient has multiple partners, but if the patient partner has multiple partners, that will be a concern. So it's important that that is considered. And as I said, there's an increased risk with PIDs with insertion, but usually if that is the case, we can treat that. The next product, and again, they recommend not to take it out. The next product is a progestin-only rod that is implanted subdermally. It's called Nexplanon. Again, the early products had like 3 rods or 1 with 5 rods, and this actually call it Nexplanon because it's the next generation of implants, and certainly this one doesn't have any of the concerns that the previous product has. So it's quite easily to insert. It takes few seconds to insert once you're in the office, and it's quite easily taken out as well. So it's not something that, like in the past, have been associated with, difficulty extracting, and some women having scars in that area. That's not longer a concern. I guess to get that a lot better. So these particular products are, again, very, very effective, almost as effective as we will see shortly as a sterilization. There might be some concern over time in patients that are overweight. This particular, the Nexplanon, can be left in place and is effective up to 3 years. But over time, there's a concern with overweight patients that there might be decreased efficacy. So it's important to have that consideration, even though, again, it's not a contraindication, but it's a concern. As I said, patient can have, when it's taken out, fertility returns right away. So contrast with Depo-Provera, it's easier in terms of family planning. It can be associated with irregular menses, but if we look in terms of some of the benefit of this, patient with drug interaction, patient with contraindication to estrogen, as we will shortly see, really will benefit from this particular form of contraception. So this is the next, so those are your contraceptive methods. We went from natural family planning to long-acting reversible agents, or LARCs. And now how do we go about this? So I'll give you some hints. This is important. You can search this. Obviously, this is, and check the CDC website, and all of this information is available. And the reason I'm telling you this is because this is 2016, so I suspect that maybe even when you go on rotation, they may be updated, okay? So to be continued. So the way we look at the combination of contraceptive, and this is our, you said here, US medical eligibility criteria, they're not the same for every country. We look at the patient-specific characteristics, and we'll go over that in a moment, and we just decide if there's not potential risk, so there's no restriction, category 1, category 2, if the advantage of the method outweigh the potential risk, if the condition usually outweighed the advantage of the risk, that would be category 3, and pretty much category 4 if they're contraindicated, okay? So one of the things that I want you to know, highlight, make sure you know this, contraindications, okay? So we went through most of those contraindications as we were discussing the lecture, and when you go back and review the lectures, you'll see that I go back to the medical eligibility. So I don't want to read it to you, you can read that, right? But some interesting one, for example, obviously, you have breast cancer? No, not a good thing. It's contraindicated. If you have history, guess what I'm gonna go over? History, risk of, or current VTE, guess what? Or that's a contraindication. Now, what I want you to look, okay, so keep an eye on those, but what I want you to look at is this table, so that I don't want you to memorize the table. What I want you to see is that for most conditions that have a contraindication, for oral contraceptive or for combination contraceptive, guess what? The progestin-only contraceptive could be indicated. And the reason I'm telling you this, guys, like for example, for VTE, remember what I told you about Depo-Provera? That is contraindicated, right, for VTE in the package insert, but it can be used, or the medical eligibility criteria, and you may see this in practice, give you a better category. So even though it might not, still might be an increased risk, we still see that the benefit of using the contraception outweigh the potential risk of the condition. Just think about it in terms of VTE. Pregnancy, is that a risk? Oh, from last semester, is pregnancy a risk factor for VTE?
Yes. Yeah.
Big time. So are you trying to, obviously guys, this is not as white and blue as it looks here, but it's just to tell you that when you go into practice, okay, you will see that even though we have all these contraindications, your patients might be in this type of, particular IUDs, right? Particularly those of you that come to my clinic, most of my patients with DVT, guess what they are in? Mirena, an IUD, right? We don't put them in the copper IUD because what do we say about the copper IUD? Causes bleeding. And guess what? When you have a DVT, what do I give you? Anticoagulant. Huh. So we have these patients really bleeding terribly, becoming anemic, and then we have to give him Ferrocet. It's funny because when you come to my rotation, all the things that I taught you, you see it that first day. And you think it's a lot of information? It's not. So what I'm trying to tell you here is that even though you see contraindication on package insert, when you go to rotation, go to this. You were told about this, okay? Because yes, there's flexibility despite the package insert of the product, okay? So you don't need to memorize this. Keep in mind the ones that are contraindicated, and think that if I give you an alternative, in general, a progestin-only contraception will be a better choice for those patients. But we can talk more about that when you ask me specific questions and you have study and the specific questions come up. So And this particular table is just so it show you again the difference. You don't need to memorize this, but so that you have a relative idea of the efficacy of the different methods with the implant and the IUDs at the top, and then family planning, spermicide at the lower bottom. Okay. You don't need to memorize how effective they are, by the way. Or I don't know, the pregnancy rate per year. The next topic that we'll cover quite fast so that we can move on, oh my goodness, is emergency contraception. Couple of things in general about emergency contraception. Emergency contraception is just that, emergency contraception. It's not a form of birth control. So matter of fact, if emergency contraception is used more than once in the same cycle, we don't even know how effective it is. Okay, so it's very important to keep that in mind. So it is safe and effective if the patient had unprotected sex or the failure to the contraception. And depending on the method, within 72 hours, as we talk about Ella, that's up to 5 days. But the over-the-counters that you may need to advise patient more commonly is within 72 hours. They delay ovulation, may prevent implantation if the egg actually got fertilized, and as I said, it's not a substitute for birth control, particularly because it's not as effective if we use it more than once, okay, in the same cycle. And it can, it's not 100% guaranteed, depending on what studies you look, the efficacy could be as low as 50%, which becomes a concern, particularly with the high doses of progesterone that the fetus had been exposed to, which we'll talk about later on. This method can also be done with, using doses of higher doses of combination or contraceptive, but with so many products, it's just easier to recommend the patient because the doses certainly will depend on what progestin the patient is on and so forth. So it's easier just to buy, although more expensive, the different products available in the market. So usually you take one tablet as soon as unprotected sex for or up to 72 hours. Concern here is that this dose can cause significant nausea and vomiting. So if that happens within 2 hours of taking it, guess what? It's recommended that a second dose be given. Very important, this patient needs to be monitored for pregnancy. If the patient develop, because they're associated with ectopic pregnancy, the patient develop abdominal pain, should advise the patient that they need to take that seriously because it could be a symptom of ectopic pregnancy that obviously need medical evaluation. So certainly that was some part of the counseling you don't want to forget. The other product, Olipristal or Ella, is a prescription product. It's not an over-the-counter product. Obviously the prescription needed to be given before. So many doctors do that, and it can be used up to 5 days of unprotected sex. The problem with this is that, again, this is very similar to RU486, so there is concern with teratogenesis if the patient does get pregnant. Same concern with abdominal pain and the possibility of ectopic pregnancy. And again, it's something that is not used as a form of birth control, but as an emergency contraception, okay? So with that, we move to pregnancy and associated disorders. Do you have any questions about, in general, about combinational contraceptive? What I would say is, as you study, and we'll try to get to some cases, and I'll probably post some cases as well. Think about conditions that are counseling and method that you would recommend based on, what the patient medical history is. Medical history is very important. So now we move completely opposite. We'll talk about pregnancy, and we'll start with a little bit about nutrition in pregnancy. A couple of things are very important for us to know about nutrition as pharmacists during pregnancy. In terms of the caloric requirements, yes, the caloric requirements do increase during pregnancy. And over the years, how much the caloric intake should be and the weight that the patient will gain, need to gain varies. And it varies also with the baseline weight. But in general, yes, the caloric intake increase, the protein intake stays about 60 grams. Folic acid, iron, and vitamin D, the requirement for those double during pregnancy, and we'll briefly go over, multivitamins, the difference in multivitamins for pregnant patients. Other nutrients, there is an increase in general, about 20%, obviously. Every time I study this, something slightly changed, so to be continued. Very important with vitamin A. Vitamin A is a tricky one. The requirements do not seem to increase during pregnancy, but certainly low vitamin A levels have been associated with teratogenesis, and guess what? High vitamin A levels are also associated with teratogenesis, so we briefly go over that. Most of these nutrients could be supplied with a good balanced diet, but who eats a well-balanced diet? Probably no one. The one thing that we do need to supplement, so yes, multivitamins, it's fine. Like when patients say that, I'll just, take a multivitamin. But that's me. The iron, however, does need to be supplemented. If we don't supplement iron, the patient do become anemic. And the iron supplementation is about 30 milligrams of elemental iron. So briefly, let's go over these nutritions for the bottom line. You do not need to memorize RDAs for some of this stuff, but what I was going to tell you is that if you don't meet the RDAs for vitamin A, the risk for a vitamin A deficiency is blindness, premature birth, and low birth weight. So certainly, vitamin A is needed. In the other hand, patients that take up to 10,000 units per day of vitamin A, remember that's associated with retinoic acid, they do have a higher increase, like a 5-time higher risk of malformation. Patient that just meet the RDA. So it's important to keep that in mind. And the reason I'm telling you this is because some general multivitamins do have higher levels of vitamin A. So certainly it's not something that we supplement, it's just something that we just maintain the RDA. Folic acid, again, very, very, very important, particularly in every woman of childbearing age. We do know that supplementing iron, particularly, with enriched breads and pastas and all that, which actually that just increased a few years back to increase the folic acid intake of women of childbearing age. We know that supplementation decreases the risk of neural tubule defects. And what is that? It could be neural tubule defects would include spina bifida, which means that the patient or the baby spinal cord doesn't close, and also could lead to poor development of the brain and the skull. So certainly these are serious malformation in patients that have folic acid deficiency. So it's recommended, and I'll tell you this so you tell your patients and you know it for yourself, that you meet the RDA for folic acid 40 micrograms per day. During pregnancy, that increases from 600 to 1,000 micrograms per day. And then very important, guys, patients that had had history of neural tubule defects in previous pregnancy do need to supplement at least 3 months with, look at the dose, 4 milligrams, okay, 4,000 micrograms from 1 to 3 months up to the first trimester, okay? And that actually had shown, as I said earlier, to decrease of neural tubule defects. So why am I telling you this? Because you're gonna be pharmacists, you're gonna keep giving this multivitamin, you certainly aren't gonna counsel the patients about balanced diet. But certainly if you have a patient that is looking for a formulation, over-the-counter formulations is for pregnant patients is what you want to recommend. Why? Has higher content of folic acid, higher content of iron, okay? And lower content of what? Vitamin A, very important. Some of the preparations, right, this is just an average. So it's important that then you go with this. Don't just pick, I don't know, some Centrum and give them to them, okay? So ask that question in women of childbearing age. And then the difference between over-the-counter preparations on prescription preparations are 1 milligram of folic acid is actually a prescription dose, okay? So it's important that if you think the patient really wants to have a baby, not because of childbearing age, that you suggest that they do prenatal care and they get a prescription medication, particularly if they don't have a balanced diet, because that folic acid, very important, okay? All right, the next topic that we talk about is we're going to try to really cover mostly diseases associated with pregnancy. Obviously, I don't have time to talk about all the conditions that need to be treated in pregnant patients, so we'll talk somewhat about that, keeping in mind, and then we'll talk a little bit about teratogenesis. I don't think I'll have time for that today, but certainly next class. Now we'll start with nausea and vomiting of pregnancy. It's quite interesting because, yes, if you look at some of the data, about 90% of patients in some studies report nausea and vomiting of pregnancy, okay? Now the incidence and the severity varies, and the reason this is important is because, as you will see, when we're talking about treatment with medication, certainly some over-the-counter products should be used or can be used, or a first-line therapy. So certainly I want you to understand this. The good news about nausea and vomiting of pregnancy is that the majority of the woman is resolved by 20 weeks of pregnancy. So one of the things we tell patients is that this will improve over time. The other thing that's very reassuring to patients is that it doesn't affect the baby unless, obviously there's an unless, right, the nutritional intake is affected. But really having just mild nausea and vomiting of pregnancy doesn't affect the child. Usually it starts about 9 weeks of gestation. Any nausea and vomiting before that need to be studied as something else. The onset is usually about 9-week gestation for nausea and vomiting. But if it's that, about 9-week gestation, and you assess the severity, there are different scales. Actually, the reason I'm putting this scale in your slide, you think I want you to memorize that? No, but I want you to know that it's available. This is just the American Academy of Gynecologists and Obstetrics just put this in their new guidelines that just were published last month. And the reason I'm telling you that is because you can have a way of assessing the nausea and vomiting and recommending the patient needs to see a doctor. You can recommend if the patient, and you can recommend over-the-counter products, as we will briefly go over. On the other hand, when we talk about significant nausea and vomiting of pregnancy that is affecting the hydration and the nutrition of the mother, then we call that hyperemesis gravidae. As you would imagine, that's quite serious. It happened in a significant percent. If you look at some data, up to 3% of pregnancy, and certainly something that require hospitalization, IV fluids, and therapy. Now, the first therapy, obviously, and probably the first one that you really want to try is non-pharmacological therapy. And obviously, you want to try all those smells that make the patient nauseous, which could be anything that before didn't make them nauseous. Avoid fats, have frequent small, little higher carbohydrate meals like crackers, things that are easier to digest, and avoid having a full stomach. There's some data that pressure may help, and there's some wristbands that you may sell in your pharmacy that you can use. They're not really that effective, but you know, even placebo works, right? So that's something that you can recommend before you go into pharmacologic treatment. Now, what is interesting is that pharmacologic treatment, the first line pharmacologic treatment, and this is why I'm going over this with you, is actually over-the-counter B6, or with or without doxylamine, okay? So one of the things that we can give is 10 to 25 milligram of vitamin B6 that you can recommend. You can use Unisum, half a tablet, and as you can see, this is in the recommendations, the recent recommendations, and do this about 3 to 4 times a day. There's also prescription products available, very expensive prescription products available, particularly, let's say your patient cannot afford this, but comes with a prescription, certainly you can help them with that. That have combination of both vitamin B6 and doxylamine. The doses are for your reference, but it's important to keep in mind that yes, the first line of drug therapy is over-the-counter B6 and doxylamine. Now, after that, the next, and we'll go briefly over this because I have some tables here again for your reference, particularly if you go on rotations. But after that, the recommendations, when we look over the table, pretty much anything can be used. So after that, we can use antihistamines. With antihistamine, the data that show that are effective. Of course, we don't have randomized trials about this, but of course they're associated with somnolence, that sort of things, but pretty effective, and it's probably the next step that you want to use. After that, dopamine and antagonists are suggested. The problem with this is that, as you know, this product had been associated with dystonias, and if you use it in combination, and we'll talk a little bit about that, can be associated with neuromalignant syndrome. And it's important to keep that in mind because many times, particularly in patients that have significant nausea and vomiting, using more than one product is recommended. Ondansetron or serotonin inhibitors have good, seems to be as efficacious as dopamine agonists. The problem is that this particular product can increase QT interval, and particularly in patients that have hypokalemia and hypomagnesemia, so if that's a concern, usually we use this again in the hospital. And the other concern with this is that we don't have good data, and interesting enough, the latest report seems to have an association, and I say seems, right? These are not randomized trial, with cleft palate. So it's important cardiac defects. So it's important to keep that in mind. And then the last choice, and we'll go briefly over how to use this, is steroids. We use this really in severe cases. We're talking about refractory nausea and vomiting or hyperemesis gravidarum. And part of the reason for that, again, is that they had been associated with cleft palate defects in newborn. Remember, we're talking here the first trimester when organogenesis happened. So again, first choice, over-the-counter B6 and plus or minus doxylamine. If you look here, we can add diphenhydramine, but we can use promethazine, again, keeping in mind that those can increase sedation and dystonia, so that's not a concern. Finally, if the patient is not improving, then you can add ondansetron. You can see any agent. Keep in mind that if we use metoclopramide and a phenothiazide, that increases the risk of extrapiramidal effects, like dystonias that we talked about and the neuroleptic malignant syndrome, and also could increase the QT. And then in patients that then are more severe, ondansetron, as I mentioned, and then what's the last choice, guys? Steroids. Okay, you don't need to memorize the table, but it gives you a sense of how you put that together within the guidelines, and you're aware that the guidelines are current and recent. And again, in your pharmacy, you can also see what the recommendations are. GERD is also quite frequently seen in patients. You can see here that the prevalence could be up to 80%. It seems to be or worsen during pregnancy as the baby presses on the stomach. In terms of treatment, yes, over-the-counter antacids are the first line, so you feel comfortable recommending that. H2 blockers and PPIs, if they don't respond to H2 blocker, again, can be used. And the one thing you should avoid is sodium bicarb and magnesium trilosate. But other than that, pretty much any over-the-counter products you can recommend. The next quite common side effects that we see with pregnancy is constipation. So certainly you can try to do things with this. Sometimes it's related to the iron, the multivitamins. So certainly at that stage, it would be something that needs to be discussed with the attending or with the physician, because you don't want to really recommend to stop the multivitamins and then the patient become anemic. So it's important to keep that in mind and ask the patient to discuss it with their physician. First line obviously would be increased exercise, increased hydration, increased dietary fiber, but when that doesn't work, then the first drug of choice or drug therapy of choice is to use either bulk forming agents or stool softeners. So we can recommend to have this patient sodium docusate. We can recommend to have some psyllium. All of that is important. Keep in mind again that you don't want them to take it with the multivitamins at the same time, because you don't want absorption of the multivitamin to be decreased. If that doesn't work, then treatments include osmotic laxative like lactulose and sorbitol, or sienna or bisacodyl like stimulant. Things that you need to avoid are magnesium and sodium salts, castor oil, very important. You don't give that to patients because that could increase intrauterine contractions. And then mineral oil, which you may think is like docusate sodium in terms of the mechanism of action. The problem with that is that this patient would have decreased absorption, right, of the vitamin, the liposoluble vitamins. So this is certainly something you don't want to recommend. But again, important that these patients be treated, because certainly you don't want implantation and more severe constipation to occur. The next topic that we talked about is gestational diabetes. We'll spend some time here, we'll spend more time in hypertension. When we talk about gestational diabetes, we're talking about, obviously, diabetes that developed during pregnancy. And we'll talk a little bit about screening, and then we talked about patients that may have diabetes that had not been undiagnosed. Very important to keep in mind that this patient needs to be identified and treated, and that treatment needs to be effective. So we're not, and that, as you will see, what you learn in your diabetic lectures do not apply to pregnant patients, because in terms of goals, because these goals during pregnancy are significant more strict. Okay, so we'll briefly go over that. And the reason for that, the reason why we have more strict goals for diabetic patients is because, yes, it's associated not only with increased complications, for example, fetal loss, increased risk of malformation, and we'll talk a little bit about the goals, as I said. Babies in general are bigger, macrosomia. They could be injured during birth, And also, these babies, they don't have malformations. They could have hypoglycemia and hyperbilirubinemia. Very important to keep that in mind. If we look at mortality rate of those babies, when we talked about patients that have gestational diabetes that were not treated, compared to those patients that you treated, we're talking about a ratio of double, okay? About 2.3, and you can see here it could be even quadruple. So yes, gestational hypertension and again, untreated diabetes, very increased risk of not only complication, morbidity, mortality, and certainly something that we need to treat very aggressively, because yes, we do decrease that morbidity and mortality associated with it with treatment. So let's start with the screening recommendation. Couple of things important here, and I see a lot of patients of childbearing age that are diabetic in my clinic. So patients that have type 1 or type 2 diabetes and they want to become pregnant, need to cancel the patients on time control, right? We talk about the malformation, we talk about the mortality, and then all the other complications. You can see here, and I'm just listing it for you, that yes, we see that the risk of congenital malformation increase with is higher with patients at higher A1C levels. So yes, we need to make sure that we cancel these patients to decrease the A1C. And what is the goal before conception? Less than 6.5. Those are the numbers that have associated with lower morbidity and mortality, okay? So, and congenital malformation. So every woman, okay, that is pregnant should be screened on the first visit, particularly if they have risk factors, for undiagnosed type 2 diabetes, right? And we need to get aggressive with that. So if you have a patient that has some family history, if you have a patient that is obese, you have a patient that has past history of gestational diabetes, you need to screen that patient for type 2. If you look at the diagnosis, we can see here the diagnosis. Does this look anything familiar to you? It's the exact same diagnosis for type 2, okay, and type 1. Nothing really different with respect to the diagnosis of type 2 when the patients first come in. In the other hand, and this is a little different, if your patient doesn't have type 2, right, those the A1C is not greater than 6.5, etc. Let's just say equal or greater. Then the patient needs to be screened. All pregnant women need to be screened for gestational diabetes at 26 to 28 weeks of pregnancy. And we use the oral glucose tolerance test. This patient needs to be fasting, and we'll talk about the oral glucose tolerance test because it's a little different, and I'll show you that in the next slide. And then finally, once the woman had delivered the baby, I don't know if you remember that gestational diabetes is a risk factor for type 2 diabetes. So very important that this woman be screened postpartum for type 2 diabetes. What is different about this, this screening for diabetes here? Is it an A1C? No, it's an oral glucose tolerance test. Why? Because the A1C postpartum is not very accurate, okay? And you do that about a month to 3 months after delivery. And then very important, and I tell you this, guys, because I see so many patients that don't get screened, you should screen those patients for diabetes. Then you can do A1Cs every 1 to 3 years. I see patients that had a baby 5 years ago, they get diagnosed when their A1C is 14, right? Because they have 5 years later, because they have not been screened. So that's very important. In terms of the diagnosis of gestational diabetes, I don't need you to memorize these numbers. I just need you to know that there's 2 different tests that we can use, the 75 or oral glucose tolerance test, or we can use the two-step two-step oral, OGTT, whatever. But this is why this is important. The reason for this, and this is actually something that eventually one of the two methods will be used. The concern is, if you look, the methods are very different and the goals are different, and the concern is that we might be treating women that may not need to be treated. So right now, I don't know where you're gonna be doing rotations. Your clinic may do one test, other clinic will do other tests. If you look at the American Diabetes Association guidelines, they don't care which one you use, okay? But the reason this is important is because certainly you will call, depending on what you're using, some patients with gestational diabetes and other patients may not have gestational diabetes. But this is to be continued. Hopefully, in a few years, we'll figure out which tests really give us the best risk benefits in terms of improving outcomes in gestational diabetes. Some people criticize it because we might be treating patients that we don't need to be treated. Now, we talked about the diagnosis having the same, right, criteria if we want to diagnose type 2 in patients when they hit the door. However, when we talked about control, doesn't matter if it's type 2 in diabetes or gestational diabetes. Does these goals look similar to you? What is the 2-hour postprandial goal in regular type 2 diabetes? Yes. Wow, nice. So, but look, what is it in gestational diabetes? 120. Okay, so significantly lower. So make sure you have a sense for what the fasting level should be, our postprandial should be. Okay, so very important to keep that in mind. The first line used is certainly the blood sugar levels. But A1C, we can use it as a secondary outcome, and the reason for that, as I mentioned earlier, is that we have an increased, as you would imagine, turnover of red blood cells, and checking the hemoglobin A1C is not necessarily as accurate. So we do know that we want the A1C less than 6.5, some data up to less than 6 to decrease the fetal adverse effects. It seems that we need to even go lower than that in the second trimester because of the increased turnaround. And you can check them faster than every 3 months because the turnaround is faster. But what is the main thing you're going to be checking? Are you going to go by your A1C? No, you're going to go by your blood sugar levels. So make sure that you know those goals. What is the 2-hour postprandial? 120. Don't get it wrong. All right, so what is the first line of therapy? Obviously, the first line of therapy will be medical nutrition therapy or diet. They don't want us to call it that. So we really need to make sure that this patient needs to see a nutritionist, because obviously the nutritional goals of this patient in all the different categories like weight gain, RDAs for nutrient, and all of that, including blood sugar, right, and carbs, need to be well determined for the specific patient. But if the patient obviously is not responding to dietary intervention, then drug therapy is the next step. It is interesting because if you read your book, it may tell you that, it actually tells you that oral agents like metformin and glyburide are now first-line agents. If you look at the American Diabetes Association guidelines for this year, guess what the first-line agent is? Insulin, okay? So I will go with that. And I want you to go for what I'm telling you in class, even if you read something different in the book. So really, the first-line therapy is insulin. You'll see why in a moment when we talk about the oral agents. The reason they say that is because we feel that even though there's no long-term side effects in terms of, there's no congenital malformation associated with these agents, the older agents, We don't know the long-term benefits of these agents, as you will see a lot of patients end up in insulin anyway, but if you have a patient that certainly refuses insulin, then you can go with those alternatives. So really first-line agent is insulin. Obviously, it's a complex treatment. This patient needs to be treated in high-risk facilities where they have nutritionists, they have endocrinologists, and they're being monitored very closely because of the complications that we talked about. Usually, in terms of self-monitoring blood sugar, very important, sometimes we have to ask this to 7 times a day, right? Pre-meals, post-meal, and bedtime. And you will see that the dose requirements of insulin changes over time, even if the patient is doing the right thing, okay? So even if they're eating right, you could see that in the second trimester, they may require higher doses, seems to have some insulin resistance associated with that, and then you'll see that it may decrease again in the third trimester, so very important they monitor closely. Dosing are here listed for you, 0.2 units per kilogram, and that's pre-pregnancy weight with a concern. We can do basal insulin with postprandial insulin. Usually we use human insulins. We could, determine seems to be the recommended agent by the ADA, but certainly if you look at long-acting agents or analog insulin, they're category C, but still, they're first agents, and as I mentioned earlier, we can adjust the dose accordingly, looking very carefully at the very stringent goals of therapy that we mentioned earlier. In terms of oral therapy, as I said, if you have a patient that is type 2 and is any of these drugs, then you can continue them on those drugs. If your patient refuses, both drugs, glyburide and metformin, can be used. As I said, we don't have long-term data. The problem is that many of these patients end up needing insulin, particularly those on metformin. Like half of those patients may require insulin as well, so may as well just start with the insulin, make sure you control them. You control the diabetes early on, because again, very important. But certainly both drugs can be used in managing diabetic patients. Newer drugs, no, we don't have data, okay? So we just stick to insulin, metformin, and glyburide. Easy for you, huh? So with that, we move to hypertension. Hypertension in pregnancy has a lot of definitions. So I'm going to try not to confuse you, but it's important again that you realize what the differences are and what the complications are based on some of those definitions, okay? So when we talk, we'll start first, so we'll go over some of the definition, and we'll start first defining chronic hypertension. So it's quite interesting because this had not changed. The guidelines are from 2013. I don't know what guidelines they discuss with you for hypertension, but guess what, guys? In patients that are not pregnant, the hypertension guidelines were changed, and now we say that hypertension is 130/85. But right now for pregnancy, we say that a patient has chronic hypertension if you check the blood pressure before 20-week gestation and the systolic blood pressure greater than 140 and the diastolic blood pressure is 90 or greater. Okay, so regular definition that you learn for any time before 20-week gestation, which is actually quite interesting because early in pregnancy the blood pressure turned to lower. So it's important that you see, even when we use this, that we might not catch everyone that may have chronic hypertension before becoming pregnant. Obviously your patient already have hypertensive therapy, and you will call it, if they continue to be hypertensive after delivery, then those patients had chronic hypertension. But when your patient hit the door, the main definition here is that they have chronic hypertension if when they hit the door with their first prenatal visit, they have hypertension. When we look at gestational hypertension, on the other hand, then is hypertension, 140 over 190, after 20-week gestation, okay? Now the problem is that there's other features that can be associated with hypertension during pregnancy or with gestational hypertension. So let's go over that. If your patient has gestational hypertension and has proteinuria, and we'll go briefly over this, or doesn't have proteinuria but have any other symptoms like low platelets, has renal insufficiency, we call that preeclampsia. So let me go back to definition. Chronic hypertension before 20-week gestation, gestational hypertension after 20-week gestation. If your patient has the symptoms that we're going to go out, that we're going to describe, has preeclampsia. So preeclampsia is hypertension, or gestational hypertension and proteinuria. Proteinuria is defined as over 30 milligrams of protein in a 24-hour urine collection. Or we can do, just a spot protein creatine ratio greater than 0.3. Usually we should get those tests to diagnosis, but from the office they can just do a urine test, a dipstick, and see. +1, certainly we need to confirm that. So if your patient has hypertension and proteinuria, that's preeclampsia. However, we have changed this definition in the past few years because patient may have preeclampsia without the proteinuria, okay? And that includes if your patient has thrombocytopenia, has a creatinine clearance greater than 1.1, has elevation in liver function test that, guess what guys, doesn't have to be very high. We're talking about just 2 times the upper limit of normal, may have pulmonary edema, or may have symptoms of ischemia, cerebral ischemia, like visual changes and so on. So it's very important to keep in mind that, yes, the definition of preeclampsia not necessarily have to have proteinuria, and as you can see here, other complications of gestational hypertension are as equally important. So certainly hypertension is most of a systemic disease, right? Or gestational hypertension, as opposed to just hypertension. And the problem with that is that patients that have chronic hypertension when they, are diagnosed with hypertension, they could also develop superimposed preeclampsia when they become pregnant. As a matter of fact, the risk, as we will shortly go over, is higher. Some patients, as I said, just present with the hypertension and HELP syndrome where they have, the preeclampsia, but they actually develop hemolytic anemia, elevated liver function, significant elevation in liver function tests and low platelets, and that's actually a life-threatening emergency, okay? These patients really need to be treated in intensive care units. And then preeclampsia stop being preeclampsia and become eclampsia if the patient develops seizures, okay? And that's the problem that, again, we need to address in patients that have hypertension or preeclampsia during pregnancy. So when we talk about why chronic, and we'll talk more specifically about the treatment, but when we look at the complications either of chronic hypertension or gestational hypertension, yes, the growth retardation, okay, so that's significant. This patient can have placenta abrupta, again, where it can lead to fetal demise. This patient may need to be delivered by C-sections. Preterm deliveries, very high risk and very high incidence. We'll go over that. And then in terms of preeclampsia, as I mentioned earlier, the risk is higher in patients that may have chronic hypertension or patients that we cannot control the blood pressure. And certainly this is a concern. So we'll talk about treatments, and we talked briefly about prevention. Obviously, patients that have history of preeclampsia in previous pregnancy have higher risk of developing preeclampsia or gestational hypertension in future pregnancy. So that's a consideration. However, when you look about prevention, really most things are not recommended. So vitamin C, vitamin A, I mean, if you look at the data, all this stuff have been studied in many, many trials. Self-restriction, actually, that's not even recommended. Bed rest is actually very important, not recommended. As a matter of fact, bed rest could be a concern, right, with the increased risk of VTEs. So we don't do bed rest and we don't restrict the patients. That's actually, again, based on the guidelines, not recommended. What is interesting is that we could give patients aspirin. I mean, it has been well studied. It's not that it's extremely effective, but certainly it may reduce the risk. So it's recommended for women that have severe preeclampsia in a previous pregnancy or that had fetal loss due to hypertension in a previous pregnancy. So we do not hit everyone that has history of preeclampsia or hypertension, I should say, with aspirin, but if the patient has severe preeclampsia and if the patient has history of fetal loss, then we give aspirin. The dose is baby aspirin, right? The 81, shouldn't say that, the 81 microgram. And that seems to, again, reduce about 1 pregnancy for every 72 high-risk women treated, okay? So we're talking, again, about the high-risk population that it can decrease the risk. So in terms of the management, if we look really at chronic hypertension, gestational hypertension, and then preeclampsia without severe feature, mostly preeclampsia and proteinuria in stable patients, we treat them pretty much the same way. So here's the treatment. Look at those. Does that look any different to you when we treat them? 106, over 160 to over 105 diastolic. Is that how we treat hypertension? No. No. So remember when I was telling you that diabetes were very strict? We're not that strict with chronic hypertension. Or even preeclampsia that doesn't have severe symptoms. We don't treat unless the systolic over 160 or 160 or greater, and the diastolic over 105 or greater. Any idea why that is?
Risk of hypotension?
I'm sorry?
Risk of hypotension?
Actually, it's very interesting because guess what? It doesn't affect morbidity and mortality. It doesn't work, okay? Remember I told you it's a systemic disease? There's more to the blood pressure in these patients. Obviously, and we'll talk a little bit more about this, we'll need this to treat these patients with drugs that are safe and effective, so the old drugs is what we use, so labetalol, methyldopa, is recommended. We do not want to use ARBs or ACE inhibitors or mineralocorticoid receptor antagonists. They're teratogenic. Then we'll talk a little bit about some other agents. And then the goal of therapy, if you look here, is at the most 120, right, over 80, but 160 over 105, right, is okay. And this is important because, again, it doesn't affect the morbidity and mortality. I used to have some tables to show you that. Because of time, I decided not to do that. So it's important that you know, if the patient needs to be treated, but certainly it doesn't affect outcomes. Now, severe preeclampsia, then therapy obviously is recommended in these patients if the systolic blood pressure, or we define severe preeclampsia, the systolic blood pressure is more than 160 over 110. And very important in these patients, guys, we do need to make sure that if they are, if they're at risk of delivery, and I tell you why in a moment, that those patients actually be treated in that the baby be treated with steroids, particularly if it's before 34-week gestation, because when we see patients with severe preeclampsia and medications do not work, guess what? Guess what the treatment is? Delivery, okay? So I'm just telling you this is very important. If you have a patient with severe preeclampsia, yes, we're going to treat the mother, but we need to treat the baby. And the baby would be, we need to give them steroids, and hopefully we'll have in 48 hours, we can control the patient, and 48 hours to lead to maturation. So in patients even patients that are stable, the blood pressure is controlled, even if they have low platelets, even if they have increased liver function tests, as long as they're stable, we try to hold, we treat them and try to hold delivery. Hopefully we'll be able to control their blood pressure. Patients that are over 34 weeks gestation, delivery is recommended. Again, it's a systemic disease, very hard to treat. So it's very important that the patient be assessed and treated as needed. Another important thing is the patient receive, oh, thank you. He closed the computer, I'm like, it must be time. You guys are too good. Normally the whole class does it. Okay, so can I tell you this bottom line, sorry. If the patient is over 34 with gestation, delivery, okay? And we need to give them magnesium, guess what? To prevent seizures, not to treat the blood pressure, okay? And then we monitor, which what we do, we'll review this slide, which is what I went over when we start next week. Thank you for your attention, by the way. I like this one. I really do. Thank you for your